Thank you very much, Mark. So thank you, Mark and Anjali, for inviting me to come and speak at this meeting. So in the next 15 minutes or so, I've got to try and cover what's current and what's future in terms of options for treatment of hepatitis B. And we'll try and focus a little bit of this in the setting of HIV infection. I also have to say at this stage that 90% of this lecture will be about current treatment, and then we'll discuss future treatments in the last few slides. So let's just put this into perspective, and you've seen this slide already. We do know that hepatitis B is a global problem, and that liver disease now ranks in the top 10 of the world's biggest killers. And of that, the vast majority of mortality associated with viral hepatitis is associated with hepatitis B. And so you also know about this, that in terms of hepatitis B disease progression, there's clearly the acute infection from which you get chronic infection. And if you get infected in adult life, the vast majority will clear virus and not get chronic infection. But as you've seen from Southeast Asia, if you get infected in the perinatal period or the early childhood period, then the vast majority will go on to develop chronic infection. In the context of chronic infection, some people will go on to develop cirrhosis with the attending risks of decompensation disease, and then there is a risk of liver cancer as well. So there is an interplay between the immune system and the virus that gives you disease in hepatitis B. And this is a cartoon of what we have classified as the different stages of hepatitis B infection that you need to be aware of, because this is where the immune system and the virus try and outdo each other. Now, clearly, we've put these into clear demarcations, but the demarcations between the different stages of hepatitis B are not so clear. And so in terms of treatment decision-making, it does become a little bit difficult. So let's take that one step further and say, well, where does HIV co-infection fit into that natural history of hepatitis B? So we're all aware, as I've said to you before, that if you get hepatitis B in early childhood, you get a huge amount of chronicity, and most children enter the disease stage of immune tolerance, where the immune system's not actually fighting against the hepatitis B, and so they're getting very little inflammation. And then as they get older, they move on to the E antigen positive phase of chronic hepatitis B, and this is where most adults enter into hepatitis B. Given HIV in adulthood, if you get hepatitis B infection at that stage, then you're more likely to develop chronic hepatitis B than if you're not HIV positive. At that E antigen positive phase, these patients have higher viral loads but lower ALTs, and paradoxically increased fibrosis rates. There is a reduced risk or chance of seroconversion to the inactive carrier phase. This is the E antigen negative phase. And then there is much higher viral loads as people move into the E antigen negative pre-core promoter mutant phase. So this is where HIV fits into the natural history of hepatitis B. So I suppose in terms of treatment, the questions that we have to ask ourselves is, what are the aims of treatment? What are we trying to achieve? Clearly, the ultimate aims are to prevent progression to end-stage liver disease and death, but also to prevent hepatocellular carcinoma and to prevent transmission of hepatitis B. Now, remember, we have vaccination against hepatitis B, and we'll talk about that later in this session, and we'll concentrate on the strategies in terms of preventing progression to end-stage liver disease and death, and more importantly, preventing hepatocellular carcinoma. So the next question we have to ask ourselves is, when do we need to treat hepatitis B? And so you're sitting there wondering, what are the surrogates in deciding when to treat hepatitis B? Do we treat everybody with a detectable HBV DNA? Is it based on HBV DNA levels as it is in terms of HIV viral loads? Or do we think about it in those with evidence of significant liver disease? And what is significant liver disease? Is this based on abnormal ALTs, or is this based on histological activity and fibrosis scores? I'm going to put up the REVEAL study because it is probably the most oft-quoted study in the world of hepatitis B, and I'm sure Dr. Hung and colleagues were involved in this. This was a Taiwanese cohort study looking at risk of progression to end-stage liver disease and hepatocellular carcinoma based on factors including HBV DNA levels, E antigen status, and ALT at cohort entry. And as you can see from here, and I won't take you through into details of this, the most important factor in terms of determining progression to end-stage liver disease and hepatocellular carcinoma was your HBV DNA level at cohort entry. And so clearly HBV DNA levels are an important factor in terms of deciding who's going to progress to end-stage liver disease and hepatocellular carcinoma. So you can think about this as we think about this in the HIV model, where you're looking at a train that's heading towards a cliff, and the cliff is end-stage liver disease or decompensation event. Then your fibrosis stage at any given point in time is the amount of railway line you have between you and the canyon. The ALT, or the histological activity index, or the inflammation that you can see, is the speed with which that train is going to move towards your canyon. And then your HBV DNA levels and the immune response you're generating to that is the size of the engine that you've got. And so if you think about treatment, you need to think about all of these three factors that come together to push that train towards the canyon, which is end-stage liver disease. So what does treatment actually aim to do? Treatment aims to take people on the right-hand side box, so people with chronic active hepatitis B and people with E antigen negative chronic active hepatitis B, down to the inactive carrier phase and hopefully down to clearance of virus. And so the surrogates of treatment are HBV DNA replication, reduction, E seroconversion, S loss, S seroconversion, and the ultimate goal should be clearance of cccDNA from your nucleus. And so we have a number of anti-hepatitis B drugs available to us. As you can see here, I'll put them up as potency versus genetic barrier. And right up there are entecavir and tenofovir, and these are the only two drugs in terms of oral therapies that actually matter. I've also put stars against them because they also have anti-HIV activity. Entecavir not enough to suppress HIV replication, but enough to give you your 184V mutation. It's an L nucleoside, very similar to lamivudine. So when do we start hepatitis B treatment? One has to balance benefits versus risks. And in terms of benefits, you need to think about the likelihood of adverse outcome without treatment for this person. And then in terms of risks, the adverse effects and drug resistance that may arise if you're thinking about lifelong therapies. And so I think that there are key interlinked factors that give you the decision to treat are age, level of fibrosis and inflammation, and then your HBV DNA levels, in a cutoff of 2 to 20,000 international units is what's used by most guidelines. So I'm not going to take you through this in detail, but this is the WHO guidelines. They are absolutely fantastic, and I would really urge people to go and read them. They're freely available online. And then in terms of HBV and HIV positive patients, these are the EACTS guidelines, and this is what EACTS said in 2014 in terms of how do you assess whether the HBV in an HIV positive patient needs therapy or not, and this is based clearly on HBV DNA levels together with serum aminotransferases. I'm afraid this conference has changed all of that. We now have the START study, and so we really need to treat all HIV patients with hepatitis B, irrespective of whether they need their hepatitis B treating or not. And so the drugs that we're going to use are going to be tenofovir and 3TC or FTC-based combination therapies. And so this is going to be our new guidelines in 2015, which says any CD4 count, if you're lamivudine naive, then you have to have antiretroviral therapy regimen that contains tenofovir plus FTC or 3TC. And if you're lamivudine experienced, then you need to add or substitute one of the NRTIs with tenofovir as part of your card. So tenofovir-based regimens have been around for a number of years in co-infected patients, and we've seen a number of data sets that say that these are effective. They're effective at suppressing your HBV DNA levels, and you know, people do reasonably well in terms of clinical progression of disease. We also know that there's an issue with your nucleosides in terms of resistance generation, and so lamivudine is out there with a highest risk of resistance, with tenofovir almost having virtually no resistance mutations. So there are different genetic barriers to the drugs that we have. So if you look at the L nucleosides, and lamivudine and telbivudine have a low genetic barrier, and the classic mutation is the 204V or I, which is very equivalent to the M184V that we're all used to in HIV. Adefovir has also got a single mutation, that's the 236-2. And so if you combine two or more low genetic barrier drugs, then you would need more mutations to become resistant to them. Entecavir, on the other hand, has got a high genetic barrier, and so it needs the lamivudine mutations plus one of the other three listed on there. And so in terms of lamivudine resistance, there is data out there that not only is it just resistance that you see in the virus, but it does lead to progression of liver fibrosis as well. And so these are mutations that have acquired fitness and will give you liver disease progression. And it is more than just resistance. Remember that the polymerase gene on hepatitis B overlaps the surface gene. And so mutations that you get in the polymerase gene also give you mutations on the surface gene. And so this then leads to S antigen mutations that will either be vaccine escape or will be detection escape, because our antigen tests detect S antigen. And so these are things that we need to think about if we're going to think about using lamivudine monotherapy. This is some data from a study that we were involved in Ghana recently. So this is looking at patients with HIV in Ghana who hadn't been tested for hepatitis B and had been given lamivudine-containing antiretroviral therapies without tenofovir. And as you can see, out to 5 years, almost half of these patients had lamivudine-associated mutations in their hepatitis B. And not only did they have mutations, but they also had much more significant liver disease as assessed by transient elastography. We then switched them to a tenofovir-containing regimen, and within 2 years, most of these patients became undetectable on their HBV DNA levels, and fibrosis also regressed in terms of transient elastography assessments. But tenofovir is not without its risk. This is data from our cohort comparing to the Indian cohort, looking at the occurrence of renal impairment. And so there are risks of renal impairment with tenofovir. So what do you do with those patients that need anti-hepatitis B therapy? Clearly, entecavir is a reasonable alternative for these patients, but remember that if these patients are lamivudine experienced, then their risk of entecavir resistance is much higher. The EACTS guidelines tell you that entecavir is a reasonable option. Entecavir and adefovir is a better option if they're lamivudine experienced, or you can use reduced dose tenofovir adjusted to the renal function as long as there's adequate antiretroviral therapy in the regimen. Having said all of that, one of the new drugs that's coming through is TAF, and so this is the poster that was available this afternoon from Gallant and colleagues, and this was a switch study in co-infected patients who were switched to ECF TAF, and this is looking at HBV DNA suppression out to 48 weeks, and as you can see, this is an effective anti-hepatitis B therapy. There are phase 3 registration studies for TAF in Hep B monoinfected patients that are in progress and will report later this year, and I'm led to believe that TAF will be licensed for hepatitis B probably beginning to middle of next year. So watch out for that, and this will be a really great alternative for treating those patients. So once you've given patients suppressive therapy with tenofovir, what does it do to your hepatocellular carcinoma risk? This is data from the Swiss HIV cohort that says it reduces your hepatocellular carcinoma risk, but does not take it away completely. So this is not zero risk at this stage. And the problem with all the oral nukes is that they have little effect, even after extended therapy, on getting your S antigen levels down. And this is the key to hepatocellular carcinoma development. So what can we do in terms of sustained or durable loss of S antigen? And this is the so-called cure agenda for hepatitis B. So what we really want to do with these patients is get their S antigens down, seroconvert them to anti-S, and put them in a state of functional cure where their risk of hepatocellular carcinoma will also be reduced. And so I need you to understand that the L nucleosides that we use have only effect in terms of reverse transcription at this phase, but have little effect on the production of the envelope proteins, much of which is associated with the risk of hepatocellular carcinoma. Interferon has a broader antiviral effect and will reduce S antigen production. And so the question we then ask is, if we combine these two together, will we do better in terms of S antigen reduction? And this is a very nice study, which is a randomized international controlled trial in mono-infected patients looking at tenofovir plus PEG interferon, tenofovir plus PEG interferon for a short period of time, followed by tenofovir alone and PEG interferon alone out to 48 weeks. We've seen the results of this trial, and what's really impressive is that if you combine tenofovir and PEG interferon for 48 weeks, out to 72 weeks, you get about 10% of people that lose S antigen. And as you can see, this curve is continuing to go up. In other words, your immune system has kicked in if you use these two together in terms of combination therapy. So what may a hepatitis B curative regimen look like? We will need a number of different things that will need to go into it. It will clearly need a nucleoside or a nucleotide. We will need to think about immune activators. We will need to think about cccDNA inhibitors. We will need to think about processes that will inhibit antigen production from hepatitis B. So I'm going to put up my very last slide, because this is what the pipeline for new anti-hepatitis B therapy is going to look like in the next couple of years. So there is already a number of these agents that are in phase 2 studies as we speak. And so these are targeting different bits of the hepatitis B replication pathway. And that is what we think the future of hepatitis B treatment is going to be like. So I'm going to stop there and say thank you very much. And I hope I haven't bored you too much. Thank you.